I'm Sarah Louden from Total Health Conferencing, and thank you everyone for joining us for our second installment of a virtual town hall. This one is on breast cancer in the time of COVID. And I'd like to just go around and introduce everyone and then get started with the webinar. So right away, I'd like to introduce and thank our amazing advocacy leaders for joining us. This town hall is really focused on getting credible patient information and sharing with physicians on how to communicate with patients who may be unsure in this uncertain time of COVID, how different things apply to them. So I'd like to introduce Mayma Carmo from TigerLily Foundation, Erica Terry from Susan G. Komen, and Hope Wall from Breastcancer.org. I'm very happy to have them with us. We will then move into an interview with medical experts, and we're honored to have Dr. Hope Rugo from the University of California, San Francisco, Dr. Reshma Mahtani from the Sylvester Cancer Center at the University of Miami, and Dr. Hal Burstein from Dana-Farber Cancer Institute. We will then be joined by Danny Haber from Pfizer and finish the webinar with a fabulous patient testimonial from Sherry, who will share with you her experiences as a patient during this uncertain time of COVID-19. So I'm going to ask Dalen to have the advocacy leaders join me for just a one-on-one dialogue, and we'll get started. And as Dalen sets us up, this webinar is being broadcasted on Facebook Live, so please feel free to share with other people who you may feel may benefit from the information that we have. It'll also be recorded and shared out, so if you miss any component of it, we will be hosting it on our page after the event is over. So thank you, ladies, for joining me. I have found or come to find that working with patient advocacy leaders and groups all around the United States, and most recently Canada too, has really enhanced our ability to reach the wider audience with things that they need to know, because ultimately this is new for everyone. I think as new as it is for a patient navigating through, it's new for the doctors, it's new for us in advocacy and education. And so I'd like to start first by just asking each one of you to introduce yourselves and tell us a little bit about the organization that you represent. Mayma, I'll start with you and TigerLily.
Sarah, thanks for having me on this morning. I'm so honored to be amidst such amazing patient advocate leaders. I will say that the patient voice is so important. I'm a first-generation immigrant to this country. I came here alone at 16 years old. When I got breast cancer, I was working a full-time job, single parenting, and never imagined the power I had to change the world in the way that I have. Not saying out of ego, but just saying that one of the most important things is not forgetting that patients are people first. And so we have been laser focused on our mission and ensuring that patients know that we care about them, and giving them compassion, love, that touch, and that care. So we recently launched a program called the Pure Cat Initiative in honor of my soul twin. She passed away a month ago in 2 days. She had met, and having to say goodbye to her via FaceTime Live FaceTime was one of the most painful things I've had to do, and not being close with her. So that even as advocates, we're people, So in honor of her legacy and her life and her energy, we launched this beautiful thing that is all about her life. We have 14 programs we're offering around meditation, yoga, dancing, fitness, and reminding patients that although we're going through COVID, we're still people that need to connect and see each other and live. And so we're dealing with mental health and grief and things like that in daytime via webinars and disparities, and dealing with, we have the evening events around yoga and so forth. Also, it's important to remember that through COVID, cancer will not stop. And so we have a metastatic breast cancer disparities program we launched last year, and we are focused more than ever. We had a call before I joined. That's why I was a few minutes late joining, because we have a cohort training that we're doing. And I'm telling my girls, like, listen, facing disparities where we were last month or 2 months ago, we're going to have worse disparities because there are trials being delayed, enrollment for new patients that are having issues are being, canceled. So, we're really pivoting our work to offer some new initiatives and to really help the patients, to listen to them more so than ever. What are your needs day to day? We're looking at doing a COVID relief fund to help people, pay for certain things. And so I think that remembering that they're people first, asthma cough, people first, and then really putting ourselves in their shoes. These patients, we think, okay, well, you can drive to a doctor's office, but some people live in rural areas where gas costs $60 to get there and back. How do we help those patients who are living in rural areas and so forth? So we're literally, listening a lot, reacting with new programs, and then telling our patients that, we're still going to be helping you, support you through these programs that we began last year, before, during, and after COVID.
Yes, thank you. Thank you, Mayma. I always, whenever I think of TigerLily and the things that you're doing, I'm so proud, first knowing you, but more knowing that you're reaching people where they are with things that typically, people don't think about. So I really, and I'm so proud that you're honoring Kat in this very special way through this new initiative. Erica, talk to us a little bit about Susan G. Komen, and maybe introduce yourself and what you do at Komen.
Happy to. Thank you so much for including us to be a part of this morning. I'm Erica Terry. I'm CEO of Susan G. Komen, Kansas and Western Missouri. I represent an affiliate service area of about 117 counties. We focus specifically on intentionally going out of business. And I say that right now, which a lot of, is kind of a silly thing or a weird thing to say, but that's the mindset in which we approach every day in all of our work. Is we owe it to the community that we serve to solve our mission, solve the problem we're trying to achieve as quickly as possible. Now, post-COVID world, things have changed a bit, and we have also had to have to pivot. So we're offering an immediate solution to those that are impacted. And again, as was just referenced, dealing with a breast cancer diagnosis, not to mention now all the implications related to COVID-19. There's a lot of financial burden, so on and so forth. So we just recently launched a breast health assistance fund that is prioritizing providing some immediate financial support to those that are in active treatment. And that comes in the form of cash. And we know that perhaps if we pay for rent or a mortgage or daycare or, what have you, a copay, that might save somebody's life immediately. And I know that can be that's actually needed more now than ever. So we're very thankful that we happen to live in a very philanthropic community that has stepped up in a very big way for the breast cancer community. Parallel to that, we're not stopping on public policy work. We know if there's anything that hasn't or that has put a microscope on the need for Medicaid expansion, it has been COVID-19. In our particular two states that we represent and work on in Kansas and Missouri, Medicaid has not been expanded. And people now more than ever are finding themselves uninsured for the first time perhaps in their adult life. As a result of the economy and layoffs happening. And we know we can make a bigger impact and help more people via public policy and hopefully help get them into the system to ensure that they have the care that they need. And additionally, right now, we're also starting to think about, from a statewide perspective, what does a post-COVID world look like? I co-chair our statewide Kansas Cancer Partnership and am a part of the executive leadership for the Missouri Cancer Consortium. Both groups are designed to design and write and then implement the state's comprehensive cancer plan. And so we're talking a lot about the implications and kind of repercussions of a COVID-19 world. Now, most physicians, Komen has come out and said, non-presenting women, go ahead and postpone your screening until a little bit later time, which is the right thing to do right now, but there will be ramifications from that recommendation. So we're starting to plan for the future on how do we make up for the loss of perhaps people postponing their annual screening, or you know, the support we're going to have to step up in terms of, you know, working with our state BSAP programs to ensure that women are getting in and getting screened so that we can save their life. So that's it in a nutshell for right now. But, you know, there's a lot of things that we're continuing to expand upon. One of my passions is public policy, and, you know, the notion of telehealth now as well being a new way of care, but it's now, I mean, we can't go back now that that's been expanded. So there's a lot of implications on educating patients about how do you use telehealth. There's a lot of, you know, well, now you can see your patients via telehealth, but it's the patient forward kind of perspective of, well, how do I do that? How do I talk to my physician over telehealth? What should I expect? We're kind of navigating some of this stuff in partnership with our kind of coalitions within our region.
Fantastic. Thank you so much. And we'll get to we'll dive deeper in a lot of the things that both you and Mayma have shared in your intros. Hope, can you let us know a little bit about yourself and your role with breastcancer.org and what the organization stands for?
Sure, thanks. Thanks, Sarah. Really, really honored, as everyone has said, to be here and to be here, Eric and Mayma, with you as well. So I've had the honor to be with breastcancer.org almost since its inception 20 years ago, when I met Dr. Weiss, the president and founder. And it's been really an extraordinary privilege to be working with this community and really introducing all of the information and support that everyone needs so very much. So as some of you listening know, breastcancer.org has been around for 20 years. We are the leading digital source of information and support for women who are going through breast cancer in the here and now, to really be able to get the information and the peer support that they need to really navigate this you know, very difficult situation, be it from fear of a diagnosis, treatment decisions, recurrence, metastatic disease, whatever the situation is, right through the end of life, we are there. So we have an enormous amount of information, a huge online community. And because we have always been digital, in many ways we have been very well positioned to handle this crisis. We're used to putting content up quickly and you know, making sure we get the experts we need to cover the topics at hand. We have a very robust research news program that's ongoing. So when it became clear in February and March what was going on, we pivoted hard and we started a hub of information about COVID. And so we are actively adding new content, new podcasts, new videos constantly as the information is so quickly changing. Again, we have very vast reach internationally. We reach about 20 million people a year. And so we know that this is a really important place for people to come to get the information they need. We've seen enormous interest, as everyone has, in these topics, enormous, you know, sort of surge of traffic to the information that we're sharing. Our community is an extraordinary place online. Maybe spoke to what it's like to have to really interact with someone emotionally through Facebook, and the interactions that people have in the community and have had for years have always been life-saving. And I think now more than ever, they are. And for people who don't know about the breastcancer.org community or have chosen not to participate, a lot of people just read and they don't post. You know, we're finding people are seeing this is a new way to get the support they need. So like others, we are starting to really look toward the future and what will happen down the road. But we are laser focused right now on helping people navigate the huge confusion that's out there about what is true, what is not true, what relates to me, what doesn't, and we'll get into more of that as we continue to talk.
Yes, thank you, Hope, and thank you to breastcancer.org. So, you know, it always makes me feel so small to think about how big the community is. And, you know, when you're in your own zone and you're kind of facing your own issues and you have your own questions and your own fears and your own anxieties, that there's a whole world of people that are experiencing the same situation, but differently. In fact, earlier this week, I was on the phone with Mema in preparation for this call, and I shared that I read something that said, you know, someone said, we're all in the same boat. And the responder said, we're not in the same boat, we're in the same storm. And I thought that that was such a beautiful way to describe that each one of us are experiencing this storm very differently, equipped with very different things. You know, some of us have a comfortable place to be. Some of us have security in our financial resources. Some of us have not had to make any significant changes to our job, maybe other than the place we go and sit from 9 to 5. And then there's a whole world of other people that are experiencing this same storm with devastating uncertainty. And I think if you peel back not only kind of the logistical things that happen to people going through life, like jobs and family and children, you know, with everyone becoming an overnight teacher, when you compound that with the fact that either I've been diagnosed with, I'm in treatment for, I'm a survivor from, or I'm fighting for my life with breast cancer, now it's like a new layer of complexity that I feel like patient advocacy groups and so many of the things that you all said, you have your finger on the pulse of what people need right at this time. So Mema, going back to you, you know, you talked about sharing these unique resources, meditation, art, dancing, you know, all of these things that we traditionally wouldn't think as a patient resource, but it's a human resource, right? Like all of us need, either we've been doing it or it's something new we're developing because we've got all this time at home. Share with me how you have seen that's impacting the community when people sign up for they've never meditated before and they sign up for something like this.
You know, it's been really beautiful to watch. We first began thinking about what people needed, and we're in a global collective trauma, right? So for those of us who've been in breast cancer, we've been dealing with trauma for a long time, either as caregivers, advocate leaders, or patients. There's some aspect of trauma in that. So we've all kind of learned to start to manage these things by, you know, with having girlfriend dinners, doing other things, going dancing, whatever. But as we thought about people being stuck in the house and forgetting, just engulfed in fear, we thought, how do we make them remember that they're still alive? They can still thrive and find ways to love and self-care and live their lives. And so we have people on the dance. We have patients who are calling to our dance parties who are metastatic patients. One of my patients dialed in. She has brain metastases, and she had treatment, had been in bed for 2 days, had not gotten out of bed. And I'm like, dude, we're having a dance party in like a couple hours, come in. She's like, yeah, I'm in. And she was dancing with us. And I just,
wow.
I just wanted to cry, you know? I just seeing her dancing and out of bed, like giving her that hope as a person first, a patient, and then a patient who's metastatic. People are in the house who have been Mets patients for a long time, or even just newly diagnosed patients who are afraid to go to treatment, or afraid to go to screening or treatment or follow-up diagnostics. And what can they do at home besides work a few hours and then just kind of stare at the walls? So they're getting on in the morning, doing workouts with us. This is all free stuff. Doing workouts, meditating, dancing, doing Bollywood dancing, like, you know, ordering stuff to do Bollywood with, and just like living life. That's so important to remember that there's still life beyond all this crap that's happening right now. So the Pure Cat stuff is really, really awesome. And then we have a pajama party on Friday night. So we all just get in pajamas, have a glass of wine. And I was in bed last night. I was like, I'm getting my drink on. So I just had a glass of wine with Ricky Fairley, who's with Sisters Network, and a few other people. We just chatted about self-care and managing life through breast cancer and through COVID. And it was just a girls' talk, you know?
Yeah.
And then we have the dance party on Saturdays. And so those are things we're doing around like the Pure Cat lifestyle event. Mental health is really important to me. As an advocacy leader, I do think we overlook what we do in the space. We're just such badasses, and then you're caring for people and patients, and you go home and you're like, and there's your kids and stuff like that. So I really think that people need mental health support more so than ever. So we're dealing with that psychosocial piece, but then there's the actual other part, which is, giving patients the relief. So we're getting funds to give patients direct assistance to stay in their houses. Who should choose between, getting to treatment or feeding their kids? That should not be a choice. Yeah. Or if you're now getting oral treatment at home, the co-payment's higher. Who's paying for that if you have a rent to pay or a mortgage? So we're really approaching it from the perspective of, one thing I always said to myself, I don't want to forget where I was 14 years ago, being in that bed, being scared like shit. Sorry, I shouldn't say bad words on live, but being in the bed, being scared and not knowing what to do. And so my team we sat down and said, we're in the patient's shoes again. What do we do with this? And we're designing all these new ways to help patients around COVID. So there's more to come. We hope to launch the relief fund soon. We're looking to see if we can partner with some telemedicine, groups locally and around the country to help patients get access to treatments. And then we're talking to partners, like talked to Hope Teams earlier this week, talked to Living Beyond Breast Cancer as well, and talking to Sisters Network. We're huge with partnerships. We can't do this alone. Yeah. It's not about whose name's on the roster that got it done first. It's how do we collectively partner to collaborate to affect change for our patients with compassion and with love.
Yes, I love that. Thank you, Mema. And
You're
Erica,
welcome.
I want to switch to you because, a lot of what Mema kind of ended with was talking about public policy and, the realities that there are people that are making these tough decisions with really very limited external advice. What do I do when I have to make decisions about where I spend my money, either on my treatment or kind of feeding my family, who's now, I know I have a teenager at home. I've never known a human being to eat so much in my life. And if there are people, since there are people, moms just like me all around the country that now have a home full of kids that normally 2 meals of the day were being taken care of by their school system, all of a sudden it's been shifted to them. What do you say about that, and how is Komen, even locally and regionally, reaching out to patients to help in those ways?
As I mentioned earlier, we launched a breast health assistance fund to provide some immediate support. But as Mema said, we have to partner. We cannot do this on our own. It doesn't make sense. It's not right to not partner. And quite frankly, from my perspective, I could care less who gets credit for these things. We just want to get them done and help people. At the end of the day, that's why we all exist. That's why our organizations exist. So, we're, keeping a close eye in conversations with our local lawmakers about how some of the big decisions that they are making can have wide-ranging ROI to help the patient population, like Medicaid expansion, like Mema just mentioned, oral parity. Patients are now finding themselves for the first time who normally got their chemotherapy via IV in the hospital or at their physician's office can take it orally, but if that is not covered by their insurance and all of a sudden they're charged a $10,000 bill for what they used to have covered, under normal circumstances, that's where they're having to make those life really hard decisions between food on the table and treatment. And I feel very lucky that I'm not in that position, and that I haven't experienced cancer, and I cannot even imagine having to deal with a cancer diagnosis right now, as well as perhaps loss of health insurance, loss of financial income. I think the biggest takeaway for me is we have to all work together to try and make a huge impact to help as many people as possible. So for my organization, we're working as hard as we can to provide as much cash to people as we possibly can right now. That's an immediate solution. But like I said, parallel to that is the public policy strategy where you can help even more people and essentially get a bigger ROI on impact, which is my end goal. I want to help as many people as possible.
Thank you. That's very insightful. And I mean, it kind of matches that you're looking at this from an organizational perspective, both from what can you do today for the woman who needs something right now, and then how can we impact policy so that we're reaching a broader group of people in the right now, and we're changing things so that no matter, as these things continue to happen as we go forward, there's, safety nets in place.
If you don't mind, if I can just say,
Sure.
You're right. And it's an interesting discussion that hasn't really happened yet, meaning, we're all focused kind of right now. How can we help people right now? But we also have to think about the future. What does that post-COVID world look like? And when we all kind of come out of this, like I said, there's people that are finding themselves uninsured for the first time in their adult life. They've always had, coverage through their employer, or, many other scenarios that perhaps, we are going to have to creatively come together as a advocacy community in general, and specifically for breast, and think about, what is the epidemiology impact of COVID-19? What are the implications of long-term drug discovery and development? I've thought about this quite a bit because in my region, the University of Kansas Cancer Center has a very stellar drug discovery, delivery, and development program. A recruitment to clinical trials has, from a phase 1 perspective, has almost halted, just from a safety perspective for patients. And because of that, that means drugs aren't getting through the pipeline quite as quickly, which has long-term implications because those drugs aren't going to get on the market to help patients and save their lives. There's just a lot to think about.
Yeah, it's such a trickle effect. Mm-hmm. It's like when you think one thing's impacting one thing, I mean, there's such a downstream of what it's impacting. I was talking to someone this week, I was saying, we can't even imagine, there's no precedent. So we can't even imagine what's to come. But I agree with you that it's going to take partnerships. It's going to take people kind of putting their monikers and egos aside and say, it doesn't matter who gets credit. It doesn't matter who's at the top of the list. What matters is that we're affecting change. So, I mean, I'd love to hear that an organization as powerful as Komen is looking at things that way. So it's very, it's reassuring. I hope, as we think about the impact of breastcancer.org, I love the fact that you mentioned, and all of these resources post-program and in our sharing, when we share the program in the recording state, we'll be sharing all the resources of how to get in contact with each one of your organizations and tap into the resources that you have. But one of the things you talked about was your information library. Just that really globally, anyone at any time can sign on and find themselves in some area of your library, find the answer to their question, find themselves, find credible, reliable information that's up to date.
Right.
And one thing that I really appreciated you sharing was that even people who weren't normally participants in the conversation before may now find themselves, with the lack of their typical social structure, that forum is really where they're seeing the resource to be able to have conversations that are meaningful to them. Talk to me a little bit about that and how you think that's affecting the breast cancer community.
Sure, yeah, and I think, thanks, Sarah. I think, like Eric and Mema have been saying, there is such a trickle effect, right? And we keep reminding ourselves, this feels like forever to most of us, and my gosh, it must feel more like that to people who are in the midst of treatment, right? But it hasn't been that long yet, and yet we have such a long road in front of us. So when we think about the community and the impact, we really are eager for people, as you mentioned, people who didn't know about this or who chose to just read because they thought, I'm not one of those kind of people who wants to post. But life is so upside down and so different. Even people who have a really strong social network, or even have a really strong, they're living with their family, right? But everyone now is so stressed. that the need to find other people who really understand, as was said, we're all in this storm together, or in that particular eye of the storm, and can really help them understand. That's something that we know we can offer, and we hope that people can find. The other thing that we know from years of experience is that people want information in different ways at different times. And, and that's happening even more quickly, I think, now during this pandemic, right? There might be a day, an hour where what is really needed is that emotional support. Someone to just say, I had this surgery postponed also, and here's what I understand, and, here's how I'm getting through it. And then they might need to just read how a physician is in a transcript describing why this will matter and why this is okay, or why they need to make their voice more loudly heard so that they might have a different outcome, right, in terms of what's being decided. So to be able to bounce back and forth for people from the medically vetted content, whether they want to read it, they want to listen to it, they want to watch it, they want to be in the community, I think it's that we really, that's sort of the unique breastcancer.org piece that we bring forward, is being really there for and with people affected by breast cancer at any moment, no matter what's going on. And one more thing I'll mention, because it was brought up so many times, all of the different really sharp needs that are coming up emotionally, financially, treatment decisions, right? These are the kinds of things that we are covering in our podcast, so that we are going beyond just the medical content and beyond, just the community, if one can say just for either of those, and really helping people hear how do experts help people understand how to deal with anxiety and with loneliness and with the need to exercise in this different world. So we're really trying to come at it from every angle we can, to your point, Sarah, to give people a library of a place to go to really dip into and learn and get support in whatever way they need.
I think that's, again, for people, going back to what you're saying about people want information differently at different times. All of us have evolved in this period, which, like you said, feels like it's been forever. And when you really look at it, it's like the same length as a summer.
Yeah.
So far, but I think that's so important to remember, that not everyone's going to sign on to a video town hall on a Saturday. Not everyone's going to jump on a chat room board and start talking to each other. Not everyone's going to, pick up the newspaper and start reading things that, might apply to them. But if we can reach people where they are at the time they need something, almost seamlessly, like we thought of it already, with resources like this that, can stay on for as long as it can stay on for, and can mean things differently to people at different times. I think you're absolutely right. And it's probably one of the most powerful things about breastcancer.org, that maybe too, because it was kind of established by someone with a medical mind who's always thinking of data, always thinking of, I want to know why I'm doing certain things, or I want to know why, we approach something from a certain perspective, and that evolves. I mean, what we do today is different from what we did 2 years ago, 10 years ago, but I still think the evolution of seeing that there's kind of like a credible chronology of that, that I can tap into as a patient, is what makes the organization, one of the things that makes the organization so powerful. As we wind down this session, I've got about 5 minutes left for advocacy before we pull everybody back on at the end, so don't go anywhere. At the end, I do want to ask each one of you for kind of like a personal takeaway from this period, something that has touched you either personally, just as someone experiencing this collective, or something that you have heard about the organization has impacted a patient with. Mema, we'll start with you.
Oh, okay, so for me, I think I've been immensely touched by the human capacity for kindness, for compassion, for sacrificing themselves for the good of other people, and for life. I've seen people do amazingly courageous things that are healthcare workers, people that just risk their lives to help save other people's lives. even industry partners who are working, even as we figure out what to do, who are looking for solutions. I've seen many of you who are partners on calls, constantly talking, brainstorming. My daughter's like, oh my God, are you going to get off the phone at some point this century?
I know, the tables have turned, right?
But we're just, all the breasties are talking about how to fix these issues. And so to me, it's shown me that despite, any kind of differences in missions or separation that we're going through with COVID, one thing that remains true is our capacity to come together when we need each other. And to really, again, back to love and to hope and to making the future better. So that's been, for me, it gives me hope for as COVID clears up and the world changes, we will see changes that are going to affect us forever. But what I hope will stick is that this feeling of connectivity, even when we're apart, and appreciating when we're together, and serving each other with passion and purpose all the time.
Beautiful. Thank you, Mima. Beautiful.
Thank you.
Erica, a takeaway from you?
So I think just even to echo Mima's comments, I am so, and I think I actually really needed this, and perhaps even our country has needed this, the notion that humanity will support each other and come together, and that there is a lot of good out there. Just today we saw a national report from Governor Komen out of New York that a Kansas farmer had 3 masks to send, and they wanted to just help one frontline worker. And, that gives me a lot of hope for the future, and, as a parent as well, for the future of this country and for my the world that my children will grow up in and be contributing members of society. My other takeaway from just the whole COVID-19 experience is it has, quite frankly, lit a fire, for me at least, because I'm not realizing, but I'm being reminded that life is so precious and so short, as well as there are so many people that are day to day dealing with horrific things like a breast cancer diagnosis and having to balance children with that, or work, or whatever. And we can make an incredible impact if we work together, if we think thoughtfully, and again, if we laser focus on impact. I firmly believe that we can make a huge difference in society, and have learned together. As Mima just said, we have to partner. So I feel very strongly that's the way of the future. So for me, at least, I feel more inspired every day because humanity is good and kind, and as well as that gives me the incentive and the drive to continue to work as hard as I can every day for those that we serve.
Thank you, Erica. Hope, can you share with us a takeaway? Oh,
Erica spoke very eloquently to really what we are seeing societally in terms of, for many of us, what is bubbling up in terms of a recognition and a gratitude for the compassion that's coming forward, and the need for us all to really link arms and collaborate even more than we ever had. I would say, when I think about specifically the breastcancer.org aspect of this, what I am reminded of every day through this is that even when we can't fix things, we never can. We can't solve the financial crisis. We can't solve COVID. There are a lot of things that we cannot do. But what I see so sharply is that the ability that we all have, breastcancer.org and all of the advocacy groups, to be a trusted place for people to get their information and get support is more critical than ever. And we have to, as an advocacy community, figure out how to survive this storm, and that's not going to be easy. So it's complex, it is often inspiring, and there's a lot of work for us to do.
yes, thank you. Very well said. Well, ladies, I'm going to ask Dalen to transition us to the medical experts, but we'll be back with each other at the end. I want to, as we're transitioning, I want to highlight that, the power of patient advocacy is something that you don't really get to experience until you need it. And when you are in a position where you need it, which, you know, we're always prayerful that people don't, but the reality is that you do, you know, they're there. Their resources are there. People just like Mema, Erica, and Hope are there giving their life to the cause. And it's really inspiring to see how they have been weathering this, you know, new normal for COVID. And again, we'll be sharing resources with all the viewers on how you can tap into some of those. Well, I'm joined now by three national, if not global, experts in breast cancer. I'm so honored to have all three of you join us. Really, I was thinking about it wasn't on purpose, but the dynamic turned out that we've got someone from the West Coast, someone from the Northeast, and someone from Florida, which I'm from and often feels like a country on its own. But what's nice about that is that the country is even managing COVID differently. So where we see the Northeast just being, you know, ravaged by COVID-19, other places in the country are kind of managing through it very differently. And so I appreciate too that each one of you will bring a different perspective to where we are. So I'd like to just start off by asking each one of you to introduce yourself, where you're from, and what your practice looks like. Reshma, I'll start with you.
Sure. Thanks, Sarah. My name is Reshma Mahtani. I'm at the University of Miami Sylvester Cancer Center, and I'm based in a satellite or network site, as we like to call it, about 45 minutes north of the main campus in Miami.
Very good. Hal, can you introduce yourself, please?
Hi, glad to be with you today. Hal Burstein from Dana-Farber Cancer Institute in Boston, and a medical oncologist specializing in breast cancer.
Wonderful. Thank you for being here. Hope?
I'm Hope Rugo from the University of California, San Francisco. You can see the Golden Gate Bridge behind me in my virtual background. So an iconic reminder of where I'm sitting. And I'm a breast medical oncologist focusing on clinical and translational research and patient care at the University of California, San Francisco's Comprehensive Cancer Center.
Thank you. Thank you all for being here. So doctors, my first question to you is really going to be kind of a general question that could warrant a webinar all on its own. But ultimately my question is, what's your medical perspective on where we are with COVID-19 as it relates to the treatment of cancer care? Dr. Mahtani, let's start with you.
Sure. Well, you know, I think that it's been really a challenging time for all of us, both professionally and personally. And this is, of course, a unique time, and the situation is fluid with new information coming in very quickly. I've been particularly impressed with how the oncology community has really come together and mobilized quickly to develop strategies to really come together to make sure that we're not only slowing the spread, keeping our cancer patients safe and our healthcare team safe, but also doing it with the eye towards not limiting outcomes. So really prioritizing care in such a way that we can still optimize outcomes for these patients and really adjust to the new reality that we're dealing with.
Yes, thank you, thank you. Dr. Burstein, your medical perspective, I'd like to maybe add a little twist to the question by saying, you know, we look to the Northeast, which has such a concentration of academic centers. We look to them for guidance as to, you know, really how to manage data in a normal everyday practice. Have you found, kind of marrying that, what's your medical perspective? Have you found that being someone on the front lines almost makes you have to have two minds about, one, I have to do something right away, and two, I've got to kind of still be thinking about this from a broader perspective?
Well, it's been very interesting. We've been doing some national guidance for breast cancer patients, and we developed a nice guideline for breast cancer care during the COVID epidemic, and I'm going to share right now on the chat site the link to that, which has been published in Breast Cancer Research and Treatment. It's available free to everyone. And in doing that and talking to colleagues around the country, the first thing you realize is that the experience for hospitals and large clinical centers differs enormously where you are geographically right now. So we had a advocate discussion just a few minutes ago from Kansas City. In the Kansas City County, Jackson County, there have been 280 cases of COVID. Bob Wachter, who's the chief of medicine at UCSF, has been great about tweeting the daily numbers from UCSF. They have 15 patients at UCSF with COVID and 5 in the intensive care unit. In Boston, at our hospital, the Brigham, there are 166 patients hospitalized, 82 on ventilators. And in our sister hospital, Mass General, they have 350 patients, of whom 156 are hospitalized. And we are still very much manageable compared to New York, the tri-state area, which has really been overwhelmed. So, you know, when you talk to folks around the country, things seem very normal in many parts of the country. This has not turned the hospitals upside down. Whereas in Boston, New York, the East Coast in general, and pockets elsewhere, our hospitals have become COVID hospitals and everything else has stopped. And so the guidance that we've been giving people really depends immensely on circumstances on the ground, which change both over time and also change just based on where you're at. What we have found is that we've really had to radically readjust how we are managing cancer patients, just like every disease program has had to adjust. So cardiology has had to adjust, and pulmonary medicine has had to adjust, and endocrinology has had to adjust. Cancer medicine is obviously particularly compelling. The treatments are intensive and urgent. And so we and others have worked on developing internal practices to help make choices. And I think the one thing I would give this audience is that, and I think it comes through in the document, that you know, there are lots of ways to treat breast cancer, even multimodality ways, surgery, radiation, medical therapies, and the sequencing of them can be shifted or switched in a way that guarantees very good outcomes, even if the treatment sequence looks a little different than what people might have originally anticipated. And those are conversations we're having every day with our patients amid the pandemic here in Boston.
Well, I'm so grateful that you said that, because I know that there are so many patients who are questioning whether changes to their standard therapy or changes to the sequence of their visit schedule or, you know, changes to the way they're receiving therapy, like we talked about in the advocacy section. You know, normally you get it through your IV and now it's oral. Will there be a difference? There's that kind of unspoken and maybe in some cases spoken anxiety. You know, and I think cancer patients as a whole, in my experience, is you're in a position of such vulnerability that when you're on the receiving end of treatment, it's very hard to push back, because you're in a place of, I'm grateful that someone's taking care of something that's threatening my life. I don't really want to ask about how can I manage this side effect, or I don't really, in this scenario, I don't really want to ask about, you know, is this going to affect me, because people are dying everywhere and I don't want me to be, you know, take over the conversation. So I'm so grateful that you ended your answer by saying, you know, we're as an oncology community still focused on making sure your treatment and care leads to the best clinical outcomes. Nothing about that has changed. And I think a lot of people on this, listening to, you know, us talk, are gonna right away breathe a sigh of relief that there are no compromises you all are making in their care.
Yeah, that's really right. And, you know, I think the analogy I've been using when talking to patients and others about this is that back when we used to go out for dinner in a restaurant, which we haven't done in a long time, but back in that other era, 6 weeks ago, you know, usually you go to a restaurant and you have an appetizer, and then you might have a salad plate, and then you might have your main course, and then you have dessert. And what we're doing right now in breast cancer care is often flipping the sequence around. So for instance, our hospitals are not doing breast surgery, none, because they have committed every operating room to intensive care unit services. Our surgeons are positioned elsewhere in the hospital doing other work. So we're doing a lot of upfront or neoadjuvant therapy for women who are newly diagnosed with breast cancer. And so what changes the sequence? So you still end up with appetizer, salad, main course, dessert, but you might end up having the main course first, and then have your salad, and then the appetizer, and then dessert. And the point is, it all ends up in the same place. and it's going to be every bit as good in the long run, but the sequence may not be what you'd originally anticipated.
Yes, yes. Thank you for that. And thank you for that explanation as well. I think all of us will use that as a takeaway as we go forward in talking to patients. So Dr. Rugo, you know, kind of coupling with what Dr. Burstein was talking about, UCSF and you particularly have always had a passion for clinical research, and to think about active treatment in this sequence of jumbling up. You're having your dessert first, followed by salad, followed by. Do you think that same sequencing is applying to clinical trials, or are we in a scary era where clinical trials have changed in a way that maybe we can't predict the outcomes of what impact this will have?
It's a great question, Sarah, and I appreciate the answers of my colleagues also about treatment. As Hal aptly pointed out, San Francisco has been in a very different and fortunate situation relative to the East Coast in terms of both the number of cases diagnosed and in particular the mortality. And there has been some suggestion that the strains actually of COVID-19 varied somewhat, as one would expect. This is a new virus, but hadn't been thought to be the case, where potentially something about migration patterns, travel, the virus on the East Coast, and more than just, how close people live together is, because I don't think Boston is that much different than San Francisco. And it really has made a huge impact on the number of cases and the mortality that we're seeing. We know that comorbidities or, for example, having other medical problems plays a role. But for that, as we think about how this affects our care and clinical research, what's been interesting is that we don't really have a good handle on how a breast cancer diagnosis or treatment for breast cancer alters your risk, both for getting the virus or for having more serious consequences from the virus. Really the most significant factor that we're looking at, who's at risk for serious toxicity. Because although we do understand risk factors, this is in no way complete. There are clearly people who are getting sick where we wouldn't, mortally sick where we wouldn't have expected that. So I think that, we are seeing big differences, and that affects what we're doing. For example, as Hal mentioned, they aren't doing surgeries. We now are screening everybody for COVID-19 before they have surgery, and have gone back, just starting to go back to more elective surgeries, for example. And all of this affects clinical research. In addition, we had always focused on neoadjuvant therapy in patients who could receive it. I think there's more of if you have a small hormone receptor positive cancer, that you could, particularly for our older patients, take hormone therapy for months before you do surgery. And we already know it has absolutely no adverse impact on outcome. We can talk later about how there may be other impacts on standard of care, but I have to say, our order per se hasn't changed much. And again, I think although we are really trying to limit exposure in the cancer center, it probably has to do with the specific treatments we offer breast cancer patients, and again, our own situation in California. So how does this affect clinical research? When this all came about, we actually had all of our clinical research personnel work from home. And that was an early impact. Now they've been working from home for 6 weeks. So the first thing that's done is actually really change very much the way we take care of our patients who are already on trials, where we can Zoom in our research personnel during visits and are signing most of our orders and assessments by a DocuSign, which is fascinating. And I expect that this is going to continue as we move forward, because now we're all thrilled that we have DocuSign instead of huge folders full of paper to sign every week. But the other thing we've been doing is really thinking about, okay, if you're already on a clinical trial, did we really need all those visits, labs, EKGs, et cetera? And are there ways that we could pull back without impacting the safety assessments, both for the purposes of understanding the drug safety, but also for the safety of our patients and in understanding the effectiveness of treatment? And we have already, in our patients on oral therapy, really markedly changed our visit structures to be much more telemedicine based when we don't need patients to come in for a physical exam or an intravenous treatment. The biggest impact is, as you note, is on research today onward, starting 6 weeks ago, really. Some of our sponsored registration trials. Now, what's your registration trial? This is a trial where you're taking something that might be better than our standard and you're testing it against the standard. And those trials, which could lead to an approval, so the drug is in the community, they have a lot of specific testing, and the companies that sponsor these became very anxious that they might not get the information that they need. So a few of these trials have actually closed to accrual, as have some of our even earlier trials, so that it's not closing forever, but for now, you can't enroll patients in the trials. And that, we know, will delay getting the result at the end. So that's an unfortunate sort of fixed problem. What we do with the trials that we have that aren't in that situation is very much based on individual institutions. We are not doing, as Hal and Reshma suggested, studies that are purely for research only, because we feel that it puts our patients at risk. So some trials can't continue forward. However, we're very much trying to continue enrolling in the trials where there are agents that will really benefit our patients. And trying to work this out as a balance is a challenge for all of us. And as we start reopening, it's even a greater challenge.
Yes, thank you.
Sarah,
Thank you
just
for that.
a few things I just would want to add to what was already said, just to kind of build on that analogy that Hal used of different orders of things. I think as we have a lot of patients on this program, one thing that I would say is that sometimes when you talk to a friend in a different state, you know, that order may be different than what you're getting at your institution. So again, just to recognize that a lot of this is being done with multidisciplinary input, and with regards to resources available, and with regards to the impact that the virus is having in the local area where you are. And really with an understanding of the biology of these subsets of breast cancer. And again, just to echo what was said about clinical trials, really trying to just prioritize very much those studies that are available for patients who don't have other good options, and making sure that we're keeping all of our research nurses and staff also safe and our patients safe. A lot of these trials require a lot of visits back and forth to the cancer center, and that also has to be factored in.
Mm-hmm. Dr. Mahtani, thank you for adding to that, and thank you to Dr. Burstein and Dr. Rugo for you know, just a really comprehensive look at both what we're doing kind of overall in treatment, and then what we're thinking about clinical trials. Before we get into maybe talking a little bit more specifically about active treatment, Dr. Mahtani, I have a question that kind of ties back to what Mayma from TigerLily spoke about when she was introducing what TigerLily stands for, and that's disparities. So you and I are both in South Florida, and I know the University of Miami really focuses a lot on disparities. We've got such a diverse population. You know, we've got an immigrant population, we've got populations from Haiti, from the Dominican Republic, a large Latin American population, large African American population. You've got rich, you've got poor. I mean, we run the gamut in the Tri-County area in South Florida. Do you find that there has been, or maybe should be, more of a focus really nationally on how we're managing patients with varying degrees of access? Talk to me a little bit about how you feel about that.
Yeah, I think this is a great point that you raise. You know, every situation, I think someone had made that I think it was you who made that analogy of us all being in the same storm, but having being in different boats. And I think a lot of this has to do with access to care. And I think this type of program really helps bring together advocacy programs and industry and things of that sort that can partner together to really bridge those divides and make sure that patients all have the same access. But unfortunately, it's not the case. And I think a lot of work still needs to be done in that regard.
Mm-hmm, mm-hmm. Okay, I'm gonna pivot a little bit and talk specifically, not, you know, I don't want to get in kind of the weeds of specific treatments, but Dr. Burstein, we had, you know, in preparation for this town hall, we invited the audience to send in some questions. And there were a lot of questions about specific treatments. If I'm on X, what should I do? And, you know, we can't really go into specifics, but maybe in categories of therapies, do you find that you're giving guidance to one set of patients over another in terms of what's the most important thing they should be focusing on therapeutically at this time?
Sure. I just want to follow up on what Dr. Mahtani said, because I think it's really true. You know, at the public health level, the disease is rapidly becoming in the United States a disease of the historically poorly treated. So it's the poor, people of African American or Hispanic backgrounds, the elderly, the nursing homes are being ravaged here. And in our own practice, we've moved, as Hope was alluding to, a huge percentage of the contact with patients to telehealth or digital contact. But the same problems then persist because of the nature of American culture. So people don't have access to internet services, or they don't have computers that run programs, or they're too old to, you know, grapple with this, or people have other health problems, don't really have often the technological savvy or people to help them. And, you know, I think that one of the tragedies of this epidemic is it's unmasked a lot of the failures of the healthcare system to address these very fundamental problems. And we're all going to pay a big price in the short term and hopefully fix that in the long term. With respect to breast cancer therapeutics, I think you can speak really easily about a few things, and then there's hardly any data, and it's really hard to speak about other topics. So women should know that hormonal therapies, agents like tamoxifen, aromatase inhibitors, fulvestrant, drugs like that are totally safe so far as we know. There's no reason to imagine that any of those treatments affect your immune system or your ability to fight off the infection or anything like that. With chemotherapy drugs, we are trying to maintain the type of schedule and dosing that we typically use. We're using additional supportive care, particularly growth factors, to make sure that we reduce the possibilities of neutropenia if there's any likelihood of neutropenia. And then there have been some tweaks to various, you know, scheduling issues. So sometimes you can give chemotherapy, for instance, once a week. Sometimes you give it every 3 weeks. And so, you know, based on the convenience factor for the patient and their comfort level leaving the home, we've been responding to those demands. But again, those are essentially neutral in terms of both long-term risk and benefit from the treatment. Some of the newer targeted drugs that we use in particularly advanced breast cancer may carry some risk. We don't really know. There's no data on, you know, if you're taking a drug like a CDK4/6 inhibitor, you know, does that really increase your risk of being infected? Or if you get infected, does it in any way affect your long-term vulnerability to a COVID infection? So I think common sense goes a long way here. We're trying to adjust some of the doses there where we want to avoid having patients need extra testing. We want to avoid having them come to the emergency room, and yet we still want to give them good care. Radiation therapy can be very safely given. Again, it requires trips to the facility, which patients may or may not be comfortable with, but there's no reason to think it predisposes to any infection otherwise. But one of the things that happened when we put these guidelines together is it reminded people that some of the courses of radiation therapy that people often get can be adjusted with zero negative impact. So for instance, in early stage breast cancer, they're very high level data that giving 16 fractions over 3 weeks essentially is every bit as good as giving 25 fractions of radiation therapy over 5 weeks. Let's use the shorter regimen. In treatment of painful bone lesions with radiation therapy, 5 or 10 treatments actually is not necessarily any better than 1 or 2 or 3 in terms of controlling the symptoms. So let's use those shorter courses of radiation therapy where we can safely and appropriately. So those are the kinds of things that, you know, we've been thinking a lot about as we are interacting with patients. And, you know, so far, with a very small sample size, even in the recent weeks, you know, we fortunately have not had patients who have gotten unduly sick or had other problems. But I think that patients are wise to use a lot of precautions, appropriate social distancing, appropriate hand hygiene. The hardest part for our patients really has been both the general worry And secondly, when they're actually at the institute, we have changed our operations. So for instance, you're not allowed to bring a buddy or a family member into the treatment center, or if they're hospitalized, to visit them in the hospital. It's made the treatment experience a lot lonelier and more isolated than people are used to. And I wouldn't say that getting chemotherapy was a party, but many of the listeners on this webinar may know that, you often bring in friends and you have a little snack and there's sort of a socialization piece to it that makes it more bearable. That we are not able to offer patients right now, and that's been a real hardship. We're very worried about making sure we don't spread infection to our patients or to our staff. So patients have to go in by themselves. They have to wear a mask. So we've been doing things to try and minimize the time that they're in the clinic. So we often talk to them ahead of the visit, whether the day before or that morning or something, so that they can go in, get the treatment, get out as fast as possible. Those are the kinds of things, again, that will vary geographically based on what's happening in your neck of the woods, but have changed the experience of being a cancer patient right now.
Thank you, and very, very, very useful information. Dr. Rugo, Dr. Burstein's last comments really, I want to maybe spend a little time there. Cancer is it's an emotional disease as much as it's anything else. And it's emotional between you as the physician with that, contact with your patient. It's emotional when the patient has to share that information with his or her family, with their workplace. And then it's emotional for the patient just independently as they go through the journey. As a doctor, how has it changed for you, even though telemedicine has filled a gap in that, it reduces risk? How has it changed your personal practice? How do you manage conversations that are often very difficult through a screen?
Yeah, it's been actually a very, very interesting time for all of us. As oncologists, our goal is to help patients live as long as possible with the best quality of life. And that hasn't changed, but we're used to being able to control the setting that we talk to patients in and the communication pathway, have patients bring family or friends and things like that. So what I have done is, for our telemedicine visits, what's been amazing to me is how well we can communicate. We're not talking by phone. We're talking by video chat, much as we're doing here. In fact, we use Zoom, although based on a large email questionnaire that went out, we get 40 million responses from all our colleagues. Everybody's using a different platform, but definitely based on, and this is kind of interesting, it was based originally on insurance billing and reimbursement practices that required a face-to-face contact for billable telemedicine, but actually what it's turned out to be is a really good way to talk to our patients. So although you don't have the hands-on or in-person communication, you can really have a very good conversation. And what's nice about this telemedicine visit approach is that the family can participate too. So let's say that the family are in different states, different households, different places. You can actually Zoom them all into the conference. And so everybody can be part of the discussion and can ask questions, which has been wonderful. For the patients I'm seeing in person, it's actually, the challenge we've had is trying to deal with difficult decision-making. So a patient who has advanced breast cancer, where you're changing treatment, or you're actually telling somebody they've developed metastatic incurable breast cancer and what our choices and path will be. It's very, very difficult for me. That has been the single greatest challenge, not to have family there and not to have the right sort of ability to hug the patient or just have that, touching, hands-on is such a big part of medicine and for all of us. So, what we've done with that, we are very much into workarounds. We want to protect our patients. We are passionate as a group of providers about trying to provide the best care for our patients in all ways. And so I Zoom in the family member. They can see us, or they can be on a phone if Zoom doesn't work. and they can participate in the conversation. And to me, that's really critical. I don't want to have a conversation where somebody's all by themselves in a difficult situation. The same is true when we're working with dealing with side effects, next steps, decision-making in the neoadjuvant before surgery or after surgery situation where we're talking about different choices. We really want to bring in the family members, and we've designed these, I think, very innovative ways to try and help people participate, and that's really important. One of the things that Hal was talking about was how, and a couple of times, and shared the link to the one of the articles that's come out talking about how we can limit visits and change therapy, but in a way that doesn't impact outcome. And that's been actually a really interesting conversation and one for our patients. So one thing that I've gotten a lot of questions about in our local forums that we've been doing is, are you choosing not to give treatment to patients who have metastatic breast cancer? Are you choosing less effective therapy? Are you not seeing patients who need to be seen? Or if I have metastatic cancer, are you not going to provide life-saving treatment for me if I get sick with COVID-19? So our responses to that as a community have been, no. When we're making changes in treatment, I actually think we always should have been doing this shorter course of radiation. So this is a good thing, right, for our patients in all ways. But you know, we are choosing therapy that has an equal chance of providing long-term cure. What we talk about is cure in early stage breast cancer, and the best treatment with the best outcome and the least toxicity in advanced breast cancer. We are not limiting treatment for patients because they have metastatic disease. And we aren't limiting treatment if patients get sick. I do think that it has brought up one thing, which is that for all of us, it's important to know what our wishes are if we have a fatal illness. And you know, you read these stories that are all over the news meant to scare us, I don't know, in some way or another, but also meant to honor people, is that, you know, the 32-year-old healthy man who dies of COVID, you know, you want to have your family know what your wishes are, whether you have breast cancer or not. This is just an important way I have believed long before COVID we should live our lives. So I don't think it's any different now. Yeah. The last thing is people have been afraid, regardless of having breast cancer or not, of going to the emergency room if they're sick. You got to go in if you're sick. We have an urgent care that allows you to avoid the emergency room, but there has been a tremendous effort on separating people who might have COVID from people who come in for other problems. If you have severe back pain, if you have anything that needs an urgent evaluation, don't wait because of fear of COVID. You don't want to put yourself at risk.
Thank you. All very, very helpful. And again, considering the audience, I think these are answering a lot of the questions that they have, you know, that they worry about, that right now there's such limited resources to be able to answer. So in our final few minutes with the medical expert team, I want to kind of get a little bit personal in terms of how are you managing through COVID-19 from a family, from a work-life balance perspective? I mean, I know overnight, like I said before, many of us have become high school and elementary and middle school teachers. You know, we've gotten coworkers in our home, wives, husbands, partners. How have you been managing through this? Dr. Mahtani, I'm going to start with you.
You know, one of the things that's kind of struck me as we've gone through this whole process together is that there are a few catchwords or phrases that you hear all the time, words like, unprecedented, slow the spread, stay safe. And the biggest one that I hear that kind of sticks with me is the word pivot. Because it really epitomizes what we've all had to do, both professionally and personally. And the pivoting professionally, we've spent a lot of time discussing some of the changes that we've had to make in patient care to make sure that we're still providing good care for our patients and not impairing outcomes. I think personally, I've had to pivot a lot in terms of some of the things you talked about, balancing childcare with work responsibilities. And in a way, I think this whole experience has somewhat been a good thing because it's shined the light on areas where we could do better, like we discussed disparities in care and end-of-life decision discussions that should be happening anyway. But for me personally, I think it's given me time to reflect on things that are important in life. I think it's mandated a collective pause in life for all of us. And it's really unfortunate that that the lessons that we've learned have really come at the cost of such a loss of life. But you know, we see that good times build confidence, bad times build character, and hopefully we're all going to be molded in a way that we're going to come out with some good aspects to this, or good lessons in this. And this has been my approach to try to really change and use this time to really reflect on my personal and professional goals.
Thank you. Dr. Burstein, how has it changed your thinking about, you know, the work life? You know, who are you individually, and then who are you as a doctor, kind of thinking about it that way?
It's a really interesting question. I like what Reshma just said. Good times build confidence, bad times build character. I'm not sure my character's benefited enough as yet. Hopefully
I didn't say I got there. I said I'm working on it.
So as a family, my wife is a physician as well, and we have essentially gone virtual. So we sit in front of a Zoom console all day long with an electronic health record running on a separate computer next to us, and are communicating with our patients over phone and then charting electronically. I got to say, I think that's going to stay. Not the full extent of the work, but you know, and again in Boston, probably different elsewhere, but more than half of all the visits at Dana-Farber are now virtual, and that happened within about a 10-day span.
Yeah.
And I don't see that we're going to go back to not having that tool available for patient care in the future. Patients like it too much, and we like it too much. What it has done is completely erase whatever boundaries there were between home life and work life. Some of that good in the sense that you can schedule things at different times. I've been meeting with patients late into the evening on Zoom or on the weekends even. And I like what I think it was Hope mentioned, that, you know, you can bring in family members, you know, which has really been a great thing, so that the daughter in California and the mother in, you know, Illinois can all tap into the same call at the same time. That's been a really positive development with this telehealth. And so I think that, you know, there are things that we're adapting to that we will probably retain afterwards. Also within our own group, I think, ironically, there's been tremendous effort to foster communication. So we have put in place a huge number of daily conferences with surgeons, radiation oncologists, medical oncologists, so that everybody knows what's going on. And I think that's been very good for our sort of day-to-day work. I don't know that we will continue it with the same frequency once the epidemic is passed, but it's really been wonderful to, you know, bring the groups together, and because everybody's on a different clinical schedule or traveling or going to conferences or just has different personal agendas, it's often hard to bring, you know, the whole group together. And that's been a really good thing that I think we're looking to retain as once we move beyond the epidemic.
Thank you. And Dr. Rugo, what has changed for you individually as it pertains to this kind of new normal and being sheltering at home and managing patient care differently?
You know, it's a really interesting time, I think, for all of us. You know, much of what my colleagues have said is true for me as well. I don't have young kids. My kids are grown up. So we have the tremendous gift of having my daughter in her 20s home, which is great, as she was evacuated from a fellowship in China. So that's really changed our home life a lot. My husband works in high tech and he's at home, so he works at home. I'm the one who gets up now and goes to work. Now, because we have patients on clinical trials and are getting IV therapies, I go to work most days. But like Hal, I'm doing telemedicine visits at all different times. You know, you can do a telemedicine visit at 7 o'clock at night. You can talk to patients about their results in a short telemedicine visit that we previously might have brought them in for. Actually, you know, although I agree with Hal, I think things will go back to much closer to what we had before, maybe when we have a vaccine, we don't know when. I think we're going to continue telemedicine in a much greater way than we ever did before. We used it in California more than I think in the East Coast, but So I did visits, but Medicare, for example, did not allow telemedicine visits to be billed. As of next year, they were going to change, but now the changes happened much more recently. And, you know, who knew that you could actually just Zoom in a family member from another state in order to provide that information, both for the family member and our patient? So this I think is going to be a great change for all of us, as Reshma pointed out, based on a very scary and sad situation for all of us. For me personally, I think we're working just as hard, if not harder, than we were before all of this happened, which has been kind of a surprise. Like, how could there be even more work? But we aren't traveling. So that's provided more time to be at home and with our families. But it also has resulted in somewhat of a, I think, professional isolation, which is interesting. And we have had a lot of virtual meetings, which have been nice. But I think many of our patients have felt isolated, this has also been true for us in the academic medical community, where we aren't talking as much. I'm hoping that our virtual big meetings that come up will allow us to communicate and talk about how new advances should be impacting our practice, but in a virtual way. And hopefully this will continue our advances in improving treatment for breast cancer.
Thank you. Well, I want to thank all three of you for your excellent insight into what's happening in breast cancer right now during COVID. As I asked Dalen to switch us to our next interview with industry, you know, I would like to ask for all of you to stay on, maybe answer some of the questions in the chats, and definitely remain around for the Q&A at the end. You know, one of the things that I think doesn't surprise me at all, again, thinking back to how the patient advocate leaders started this webinar, is that all of us, you know, we're humans first. And so whether you're like me, someone who runs a medical education company, or whether you're a patient advocate managing an organization, whether you're a doctor on the front lines, isolation, I think, is a word that all of us have kind of become a little bit too used to. And I think it's just as important to highlight that we've got to take care of ourselves in new ways. And that, you know, things that we never even thought we would experience, being in a home with other people, but feeling, you know, sometimes alone, these are things we have to address. So, you know, I encourage everyone listening to kind of form bonds with people that you can just pick up the phone and say, hey, I'm feeling a little down today. You know, I miss hugging my mom, or I'm worried about what's happening with my disease. Just kind of a trusted circle, and don't be afraid, you know, be vulnerable. Don't be afraid to reach out to the people that you need. I'm joined by Danny Haber from Pfizer. Before I ask Danny to introduce himself, you know, Pfizer is an organization, every time I'm in New York City and I pass the Pfizer building, I always get this sense of like, I don't know, there's this big company that's kind of taking care of a lot of things that are meaningful to me. Not just in the cancer world, but in everything medically and scientifically that Pfizer touches. And when we started to develop this webinar, we thought about ways that we really could bring people from the cancer community together and just talk about our collective experience. And so I really do want to thank Pfizer for being here, because I think it's going to surprise many of you just how far-reaching this organization is in our day-to-day life. So to start, Danny, I'd like you to introduce yourself and tell us a little bit about what you do at Pfizer.
Thank you so much, Sarah. Good afternoon, everybody. It's a pleasure to be speaking with you all today, and I hope everyone is doing as best as they can, given the current situation we're all in. As Sarah mentioned, my name is Danny Haber, and I'm the Chief Medical Officer for Pfizer Oncology. I oversee our global medical affairs organization and have nearly 20 years of US and international experience in oncology, medical affairs, and clinical development across a few different biopharma companies.
And so, Danny, we're also going to add your colleague in a minute, but what is your view of the current state of COVID and how it's impacted the cancer community, both from like where you sit as Chief Medical Officer and just in the dialogue that you're having with your teams?
Thank you. Great question. You know, Sarah, the public health challenges posed by COVID-19 have impacted just about all aspects of our lives. And this is an extraordinarily difficult crisis for the entire world. But as many speakers have noted today, the reality is cancer doesn't stop because of COVID-19. In fact, many of the challenges have only intensified. And people living with cancer and their healthcare providers are grappling with difficult questions about how to navigate care, including whether it's safe to continue treatment, whether their care will be deprioritized in a healthcare system that is strained by COVID, and what precautions they should take to limit their exposure to the virus, just to name a few. Our knowledge of COVID-19 is evolving rapidly, and we are starting to learn about its impact on people living with cancer. Sadly, early data from China indicates a higher rate of mortality among people with cancer. But there's also been very good news. We're seeing an unprecedented level of action, investment, and most importantly, partnership across the industry to combat the virus. Whether it's working to develop treatments and vaccines, ramping up testing capacity, or deploying human capital, organizations of all kinds are making extraordinary efforts to respond to this global health crisis.
I agree. You know, you turn on the TV at any given time, on any given day, and you really get the sense of what's happening in the scientific community. You know, there's big organizations testing drugs, working tirelessly on vaccines, you know, kind of ramping up the way they're thinking about finding answers for people who are going through this in real time. So it's extremely impressive to see that while you're still managing these massive organizations doing the things you know, we're always doing, it's been interrupted by, you know, really focusing on something that's real time affecting our community. So talk to me a little bit about what Pfizer is doing specifically to combat COVID-19.
Thank you so much, Sarah, for the question. Pfizer very early on has outlined a 5-point plan to help rapidly bring forward therapies and vaccines and prepare the industry to better respond to future global health crises. First, we're sharing tools and insights. We're making the vital tools we develop available on an open source platform to the broader scientific community, and to sharing the data and learnings gained with other companies in real time. We're marshaling our people. Pfizer has created a SWAT team of our leading virologists, biologists, chemists, clinicians, epidemiologists, you name it, and other key experts to focus on solely addressing this pandemic. We're applying our drug development expertise. We're committed to sharing our clinical development and regulatory expertise to support the most promising candidates that smaller biotech companies bring forward. 4, we're offering our manufacturing capabilities. As one of the largest manufacturers of vaccines and therapeutics, we're committed to using any excess manufacturing capacity and to potentially shifting production to support others in rapidly getting a potential COVID-19 vaccine or therapy into the hands of patients as quickly as possible. And last, we're improving future rapid response to address the future global health threats. Pfizer is reaching out to federal agencies, including the NIH, the CDC, to build a cross-industry rapid response team of scientists, clinicians, and technicians able to move into action immediately when future epidemics surface. As part of these efforts, I want to highlight 3 specific steps we're taking. We are working to develop an investigational antiviral compound to treat COVID-19 and are evaluating other therapies that have scientific potential to help infected patients fight the virus. 2, we have entered into a global collaboration agreement with BioNTech to co-develop a potential messenger RNA-based coronavirus vaccine aimed at preventing COVID infection. On Wednesday, BioNTech and Pfizer received regulatory approval from German authorities to commence the first clinical trial of COVID-19 vaccine candidates in Germany. And soon we will also be in the United States following the FDA approval of our IND. In the US, we have also temporarily adapted some elements of the Pfizer Patient Assistance Program to accommodate the evolving needs of patients we serve and ensure they get access to their medicines without interruption. To date, upon request, we have responded by increasing patient supply during the quarantine where possible, approved telehealth prescribing, and more.
You know, as you go through some of the things that Pfizer is doing, I can say, as we're going to hear from Sherry, a patient going through the experience after my last question to you, but you know, it's so encouraging. I myself have an autoimmune disease, and you know, every day I'm looking at the news thinking about what is the state doing to open and that state doing to open. And you know, you've just as a human, but also as a patient, someone who has something that causes your fear and anxiety to kind of peak, we're not hearing about what's happening in moving forward vaccines, which really for patients with immunocompromised systems, that's the only way we're getting back to normal. You know, the greater population may have the ability to kind of go around and use masks and hand washing and all of that, but people who are very high risk, we don't. And so we're relying on companies like Pfizer, and I just want to stop and thank you so much for what you're doing as a chief medical officer, both in cancer and then what you're doing as part of the greater medical leadership at Pfizer. I really just want to thank you because there are so many of us living under this kind of like umbrella of fear of when will our new normal come back. And so I really appreciate that. Danny, my last question to you before we move on to Sherry is, if you had one message for the cancer community, what would it be?
Sarah, I'm so impressed with the resilience that people living with cancer survivors and the broader community have shown during these unprecedented and sometimes frightening times. It's truly inspiring. Now more than ever, we must continue to work together, support each other, and maintain our sense of closeness. This is a time to lean on one another and act as one team to really respond to this urgent public health challenge. I remain personally very hopeful that through our science, the medical expertise, and collective efforts, we will defeat COVID-19. So let's remain hopeful and let's put our hands together and we're gonna get out of it.
Thank you, Danny. Please stick around for the Q&A after. I know that there's gonna be a number of questions on specifically for you. Dalen, as I ask you to introduce or get Sherry queued up to introduce, we did this program last weekend. It feels like last year. We did this program last weekend for colorectal cancer, and we're going to be doing a series of all different types of cancers, really by request. We've had so many people say, what about me, what about me, what about me? And again, it really is in response to the fact that when you turn on the news or you call your friend or you are scrolling through Facebook or Instagram, there are so many messages that just overwhelm you with hopelessness. Death tickers and stories of, like Hope was saying, maybe stories that were meant to kind of inspire you or honor people that have passed, but it really terrifies you. And I think webinars like this, programs that the patient advocacy organizations put on a weekly basis, opportunities like TigerLily has to connect for meditation, for dance, for pajama party nights. Really, these are opportunities for us as humans to just connect on a different level and say, let's cut through the noise. There is a very serious thing happening, but we need to kind of also think about what's happening in our own daily lives. And so I really feel gifted to be here with Sherry, who will share with us, her own experience with someone who's been affected by cancer, and then also someone who's been affected by just the environment of COVID-19. So Sherry, thanks so much for joining us. I'm so glad to have you. And
thank you for inviting me.
I don't want this to be as much Q&A as just as much as a platform for you to share what you think, you know, brothers and sisters in your community might want to hear from someone who's living it alongside them. So I just invite you to, you know, talk to us about something that you think is important for us to know.
I will just somewhat tell you my story. I've been on Ibrance now for about 2 years. I was diagnosed about 2 years ago. I'm under the care of Dr. Mahtani, and I am so grateful. I am so grateful. I love University of Miami Sylvester Health Cancer Center. I really feel like I'm in great hands. Dealing with COVID has really kind of affected and somewhat isolated me even more. I'm afraid of the country going back. I'm afraid of people coming in and out. I have 3 boys. I haven't seen them. They're all 3 home right now, and they're down at their dad's house because, you know, they call me and we Zoom conference sometimes, but I miss them terribly. I chose to return to college shortly after I was diagnosed because I felt it gave me something else to think about, something for my mind to do. And so I apologize for my appearance and whatnot today. Yesterday was my last class and my final, and I had till midnight to get it done, and I got it done, but I could probably just lounge all day. But I do feel I'm afraid to go out. I only go out maybe once every 2 weeks to do a major grocery shop. I bring a couple paper towels, and I have a thing of Lysol spray and cleaner in my car, and I'll take a paper towel and I'll open a door with it, or I'll open I'll use a handrail, and then it immediately gets thrown away. I even have a little Ziploc bag in my car that I throw everything inside. It's the unknown. I've always said, tell me what I have to know, and then I can deal with it. But not knowing really has driven me crazy. And I would say during the last, 6 weeks, 2 months, I found I struggled a little more with depression, sometimes motivation. But I don't have another class until the second half of summer semester. And I'm going to use that time to work on me, force myself to get out, walk in the morning, walk at night. I've always been a healthy eater since beginning this whole experience. I'd like to be plant-based, but it doesn't give me enough protein, so I have a lot of fish, tuna steaks, fresh spinach with some almonds is like a meal for me all the time. That's the best, and it's just complete protein. I feel tired sometimes, and I think it's even more tiring just not getting up and going to class. Just, I'll feel, when is this going to end? And we don't know.
Yeah. So many of the things that you have just shared. First, I want to stop and say, good girl, congratulations.
Thank you.
That's kind of amazing. And it's also inspiring to know that that's what you chose to do shortly after. So congratulations on that. But I'm with you on so many of the things that you said. You don't know, we don't know. And having everybody from, you could have the president of the world on, they don't know. No one knows. And it just, I think, what you said something about, like, as a patient, and I think a lot of times too as women, like, tell us what we need to do, and we'll create our plan. Like, we'll create our roadmap, we'll create our task list, we'll create our, all the resources that we're going to need to kind of get to the finish line. Women, moms, like all, that persona, we know what to do with that. And I think the thing, when you mentioned that sometimes you feel a little bit depressed, it's like the depression I feel comes from the fact that we have no tools to create the roadmap that we're so used to creating. And then you couple that with the fact that you can't hug and kiss your kids. And that they can't hug and kiss you, and you can't, run your fingers through their hair and say everything's gonna be fine. I think that all leads to these feelings of uncertainty and hopelessness in a way. I hope that you can agree with me, Sherry, though, that today, you know, hearing from what advocates are doing and kind of how the medical community is pulling together, and especially big companies like Pfizer working double time to try not to just solve the problems of, you know, the cancer community as it relates to their products, but bigger things like, let's get a vaccine for this thing. I have felt very hopeful having gone through these couple hours and hearing like, I'm really not alone. And there really are people out there that are helping to build the tools women like me and you need to get back to a sense of normalcy. Talk to me a little bit about how you think programs like this can help fill in some of those gaps that we may be feeling without them.
I think it's just that it's more specific to me. Yeah. If I watch a CNN or a World News Tonight, something like that, it's just information about what's out there. I don't feel it really pertains to me, and I'm still in limbo. And that's the feeling I'm feeling. Yes, I could move forward if I knew, I think if I knew there was testing, if I knew more fact about what's going on, but I don't feel that way. And I feel like we're all kind of floundering, wondering what's going to happen. And that's really why I think school is really big. And I have a good support network. My oldest and my youngest son, 27 and 18, each of them call me every day. Mom, just checking in on you, just checking in.
That's important.
The oldest one, due to COVID, has broken up with his girlfriend, so we spend long times hearing about that. And that's fine, I love that, but I can't hug him or tickle him or you know, something like that. But I have my brother, I have my mother, we're all within like a 3-mile radius. My sister-in-law, we're all here together. And when I feel down, a lot of times I call them, or it seems like instinctively, maybe my cousin or my best friend from New York will all of a sudden call. And then it just perks me right up, and there's still world out there. There's still normalcy out there. I told Dr. Mahtani earlier this week, I went out the other day just for a drive. Just for a drive, just to get out and feel like I was doing something.
Yes, agree. No, I appreciate again everything that you're saying. I think that it resonates with all of us, you know, who are going through this thing together. You know, just ways that we can stay connected and ways that we can, you know, spend time to be grateful. I mean, that's one thing someone said to me the other day, like, as before you even start your day, on your notebook or in your planner or on a Post-it note at the corner of your laptop or computer, just write one sentence of what you're grateful for today. And every time you get to feeling that, you know, what's going to happen or hopeless or whatever, take a look at it, you know, like remind yourself that the feeling you had this morning, nothing changed about it. You know, you're still grateful for the roof over your head, or, you know, your husband making you coffee this morning, little things that you normally would take for granted. Sherry, I so appreciate you sharing a little bit, being vulnerable with us. I'm going to ask you to stay on too, and Dalen, I'm going to ask you to bring the whole panel back on so that we can spend some time with Q&A. I find that this has been, just like last week, I feel like the time goes so fast with this, and last week we had overwhelming response. You know, almost 2,000 people this week have viewed the webinar for colorectal cancer. I don't think it's going to be any different for breast. I think it'll be, you know, something that people have an appetite for listening to, because it brings positivity, and like Sherry said, it's about me. You know, this is something about me right now in a world that's filled with a lot of noise about a lot of sad things. This is kind of like hope in the middle of the noise that's directly related to me. So I've got most of the panel back up. I am only waiting for Dr. Mahtani and Mayma. While we wait for Mayma to join, we're also joined by Lynn McRoy, also from Pfizer. Lynn, thank you for joining us in Q&A. So let's take a look at some of the questions that have populated while we've been going through this. So, you know, a lot of patients have been asking about patient advocacy programs. You know, how do we get involved? So Erica, I'm going to send this question to you, and since we only got about 15 minutes, We'll try to keep all of our answers really concise. How can a patient watching right now get involved with some level of patient advocacy in their community?
I would highly suggest, searching for either for us, the Susan G. Komen in your area, or visiting Komen.org nationally. We have a really strong grassroots program, as well as I kind of emphasize the importance of being involved in public policy to help influence broad sweeping changes. I encourage you to visit those websites and follow us on social media. We're always actively pushing out, call your legislator, donate, or perhaps help us connect to those that need support the most. So I would encourage via websites or social media.
Thank you, thank you. I know Hope Rugo, we hope, both Hopes have said that it's unusual to have another Hope on, so I'll have to say, Hope Rugo, Hope answered on the chat board. Reshma, I'm gonna actually send this question to you as well, since you have small kids. We have an attendee asking, how do I talk with my kids about breast cancer? They're scared that COVID-19 might be worse than my cancer. So how would you talk to your kids if you were in this situation?
Thanks for that question. I think a lot of those conversations are really specific to the age that your child is, giving them information that they can digest given their age. I think that this is a scary time for all of us, right? Even patients that don't have cancer, that have other comorbidities, that are older, we're all scared. And children process things differently. So I think it's important to be reassuring to children that, I'm safe, you're safe. If you're dealing with breast cancer treatment, reassuring them that, mom is still getting treated, I'm still being taken care of. A lot of reassuring statements, I think, are important, because children need routine and they need safety. They need to feel safe, right? Yes. So I think that's something that we're all struggling with. But of course, it has to be really catered to the age of your child. And one thing that I've been really happy with that we've had at Sylvester is we've had a lot of support from our cancer support services. So when patients are expressing these kinds of questions or concerns about family and how to interact, and just anxiety surrounding the situation, the feeling of social distancing hasn't become social isolation, because our cancer support services have been really creative in allowing connection to be maintained, doing things like meditation over Zoom, chair yoga, exercise, counseling sessions. So even some of these things can be used as a strategy to help us through all of this, all of these difficult discussions.
Mm-hmm. Thank you, thank you. And then Dr. Rugo, we had a question that said, what should I be doing about scheduling my regular flu shot? I think this is a super practical question that's probably on the minds of a lot of people, especially as we're seeing more and more of the task force updates talking about this second storm that might be coming. What are you saying to your patients about the standard flu shot?
Well, it's interesting. In some ways, the COVID pandemic helped to emphasize the incredible importance of the flu vaccine. I think when at the initial, our politicians were saying that, this was just not as bad as the flu, which clearly is not the case any longer. A lot of stories came up about what people suffered severe illness and died of influenza A or B. And it turns out that vaccines, some reasons that people have not gotten vaccines are because they believe that it doesn't cover this year's strain. But actually, it turns out if you get the vaccine, your chances of having a serious illness from influenza are much, much reduced. So we strongly encouraged people, even as COVID emerged, to get the flu vaccine if they hadn't gotten it before. And I continue to encourage people to get that. It's really important, if anything, more important than ever. And so usually the flu vaccine comes out in early September, for us maybe a little bit later. And I would encourage people to get the flu vaccine. You don't usually schedule it. Usually people go in on a drop-in basis or schedule it closer to the time. But definitely the flu vaccine is a critical component, and people should not avoid the flu vaccine because of concern about going in to get it, because I think you're just setting yourself up for another risk.
Yeah, thank you for that. So, you know, when we're thinking about patients talking about gathering again, you know, going to clinic again, going back to what Dr. Burstein was saying about chemo's no party, but it often has, you know, you bring your sister, your best friend, your mom, your daughter, and it's time just to kind of be together and take your mind a little bit about what's going on. Dr. Burstein, is Farber or are institutions in the Northeast, and I know this is going to vary regionally, but are you all even talking about plans of kind of getting back to some type of normalcy?
Absolutely. We don't know when, and we don't exactly know how, but I think people are looking forward to a time when operations are smoother and less feeling sort of weird or abnormal. I got to say, in the near term, I think we're in for a new normal that is going to not be quite what we had before. I think that, you know, the patients and the physicians will be wearing masks for a while, and there's going to be different spacing out of the clinic schedule so that there's more social distancing. There will be different shift schedules amongst hospital workers to accommodate people who are potentially out for illness. I mean, very concretely, in the old days, you know, if you had a sneeze or a low-grade temperature, you might still go to work, or it wouldn't be a big deal. Now you're out for 2 weeks until the testing is back and you're feeling 100% better. So there are personnel challenges in all the hospitals and the clinics right now. So, you know, we're trying to figure out what can we do ahead of the visit? What can we do to shorten the visit so that people are at risk less? How do we clean rooms after a patient has been there? This is something that we didn't really think a lot about. We would sort of put on a fresh, you know, toweling for the table, and, you know, they would wipe off the infusion chairs. Now we're talking about sanitizing the space a patient has been in. Well, that's good. I mean, we want to protect the patients, but that's a huge effort and slows down clinical operations, and all those pieces are being thought through. And again, you know, this is not in any way unique to healthcare. So there was a thing on the airlines the other day that, you know, they're trying to figure out how do you reconfigure seats on an airplane so that people can be socially distanced. You know, what personnel protections do they need for staff or people who are flying on an airplane so they have confidence that they can fly safely. Those are all pieces that are going to come together. Before we go, I just wanted to say, and the Komen folks are on the line also, they may want to comment, that one of the most frequent questions we're getting is about mammograms. And, you know, we are not doing mammograms in Boston right now, but that's okay. For women who do not have symptoms in their breasts or changes that they've noticed in their breasts, it is very reasonable to anticipate deferring a mammogram for 6 or 12 months. Komen has endorsed that practice. The guidelines have endorsed that practice. And so I think it's good time to have some general awareness of the breast architecture and exam. But if you end up having to defer or delay your routine mammogram, even if you're a breast cancer survivor and that gets pushed back for a while, that's probably very safe. Remember, the rest of the world does mammograms about every 2 years, a little less rigorous than the annual that the US standard has been. So that's been the number one question we're getting. I wanted to make sure I tried to answer that before the session was over.
Thank you for that. Lynn, just to ask you, you know, thinking about large organizations like Pfizer and others that are looking at this kind of in this complex nature of managing real-time needs, but also looking futuristically at what changes we need to make in healthcare systems. What do you think a takeaway is that you want the audience to know regarding, you know, just at what level these things are taking place?
Sure, thank you for the question. I think one important thing that Pfizer is thinking about, and I know all of the institutions, especially those that are represented here today, can speak to, is I think all of the panelists have referenced, we won't go back to the normal we had. We'll go back to an adapted normal, and in many ways that will actually be better. And I was just thinking how great it would be to sit on a plane and be socially distant would be a wonderful change. It has nothing to do with COVID. So I think certainly some adaptations are things that will be beneficial and are useful for society at large. And one of the things is the increased use of telemedicine, as Dr. Rugo specifically emphasized. I think what Pfizer and other large pharma organizations are also doing is considering how do we operate differently and what ways can we support healthcare systems, providers, and also improve the quality of care that's delivered. And one of the ways we've attempted to do that, or are working to do that, is providing for grants that are basically a request for proposals around ways to help the continuity of care for patients on oral medications to treat metastatic breast cancer or even adjuvant therapies for breast cancer, so that we can reduce the burden on the healthcare system and increase safety for patients. So there's many quality improvement initiatives that we're publicly funding in an effort to try to improve how we go about delivering care. And those changes should travel forward and not simply be related to COVID-19.
Thank you. Thank you. That's so important to note too, because, you know, this really is about collaboration. I think the advocacy groups, as they talked earlier, you know, highlighting we're not alone. In fact, we can't be alone. We've got to partner. We've got to put all these things aside. You know, it's not about the brand anymore. You know, it's just kind of about humanity. It's about like, what can we do together as people to help combat something that's very real and very scary, and that impacts generations to come. I mean, from a financial perspective, this is a generational epidemic. So I so appreciate that. I want to end on a light note. I want to thank all of you so much for your time today. You know, last week, I keep referencing last week because we had such an amazing town hall in colorectal cancer. And I thought, like, you know, it can't really be beaten, and it has been beaten because I've loved the conversation with all of you. I've loved just the transparency and just how much you've each put into, you know, taking the time to explain to all of the listeners your perspective, where it's coming from. So, you know, in the spirit of sheltering in place, I want to go around the room with two questions. Hopefully we'll get through both, but even if we get through one, I'd be happy. So I'm going to start with Sherry. What are you binge reading or watching in COVID-19? What do you find? Well, you've been in school, but what do you find yourself binge reading or watching?
I have a new book I haven't started yet. The last one I read was the story of unknown Americans, which was really, really good. Yeah.
Okay, thank you.
But I have a lot to start now that school is done.
We've got so much time to do it. Dr. Burstein, what are you binge reading or watching?
I'm probably reading the New York Times too much. It's a little scary. But my daughter's been doing a research project on the Middle East. So we've been watching like David Lean movies like Lawrence of Arabia and things like that, which has been kind of fun. So
very cool.
We'll see how it goes.
Very cool and different. Erica, binge reading or watching? Oh, we've got you on mute.
There. So to add some levity to my life and get away from everything, I'm binge watching absolutely everything on Bravo. And binge reading, I've always wanted to read the Game of Thrones kind of series, and so I've dived into those.
Very good. And Erica, I'm with you on that. I kind of feel like in order to feel better about myself, I like to delve into the drama and mess of other people on Bravo. So I'm with you on that. Dr. Rugo, binge reading or watching?
Well, let's see. So what I think is similar to Hal, you know, we've been sort of tied to the news every day. So, you know, when the middle of the night reading has been going to Apple News and realizing they're redirecting my news. So, you know, going through various news groups and finding out what's happening with COVID and treatment of COVID, et cetera, has been, I think, a really big part of every physician's day. And then outside of that, with my adult daughter being home, we've been watching old movies Netflix. So, you know, all sorts of different art movies and things like that late at night. So that's been fun as well.
Good. It's great time together when you get to binge with your kids. Hope, binge reading or watching?
The other Hope.
The other Hope.
Yeah, I'm afraid it's been the news in terms of the reading piece, and that part is so heavy that it has driven me to binge watching on Netflix, which I rarely do. I can go months without turning the TV on, but I have gotten absorbed in a very silly Netflix series called Offspring. It's Australian, that my sister mentioned. It's about an dysfunctional Australian family that's totally lovable. And so it has been entertaining me.
Well, good. I'll have to check that one out. I haven't heard of it. Danny, binge reading or watching?
Yeah, no, I've been, of course, we started reading a lot of the news, but now I'm starting to get a bit tired of it. So what I'm trying to read is more about, you know, the research happening in COVID, meaning, you know, what is the pathophysiology of the disease? What are some of the clinical characteristics? And with that, I'm hoping that maybe we could elucidate some of the mechanisms that we could target with some of our medicines.
Yes.
We can speak about, you know, a lot of research that never crossed my mind could play a role, but actually seems that it may, and then people are doing studies on it. As far as, you know, when I want to take a bit of break from that, I watch a lot of the Food Network, trying to perfection my cooking skills.
Yes, yes. My husband has taken to watching the home improvement shows. So I'll be in the living room and randomly he'll say something like, I think we need to do something over there.
So far, there have been a lot of limited successes with baking bread in my household.
Yeah.
You have to find the yeast.
Noted.
Yeah,
Lynn, what do you binge read?
In San Francisco, there's no yeast.
Lynn, binge reading or watching?
I actually read a great book by Doris Kearns Goodwin on leadership in turbulent times, which actually gave me a lot of hope and was actually great. In terms of watching, you know, just escapism, I've watched the Father Brown murder mysteries, and man, so many people die in this tiny little town. It's unbelievable. I don't know how many, the English are fascinated by murder.
And everything's all covered up, like,
right.
Very well. Okay, Dr. Mahtani, binge reading or watching?
Well, when I think of binge, I'm thinking of binge eating, which is going on in my house. I never knew children would be this hungry so many times a day. I think there needs to be some social distancing from the refrigerator. Binge watching, I guess I'd say The Crown. I love The Crown. And you know, I love quotes. I always tell this to the kids. I've been saying this a lot lately. Reading gives us somewhere to go when we have to stay where we are. So read a good book. I have a stack of books that I've been trying to get through. The latest one I'm reading is called The Alice Network. It's about this group of spies during young women. So yeah.
Okay, thank you. Mema, binge reading or watching?
Both. So binge watching, I've been like so bad on Netflix. I'm like on there all the time. I found this awesome series called Dirty John. It's so crazy.
Oh, yes, I've seen it.
So I've been doing that, and then Dynasty is like insane as well. And then I just watch and I just drink Hawaiian and popcorn every night. And then I love it. I mean, they're all miserable. There's always drama. I get distracted.
Yeah.
Like, what's wrong with that, right?
It's an escape.
And then reading. I'm actually a writer. I love to write. So I've written like 3 books in the past 3 months. I just write. It's my disconnect from the world. I just write a lot. My latest book is called Unicorn Boss. It actually came out on Friday, but it's about leadership and dealing with leading and trauma and being a boss and doing all these awesome things while you're processing your own life and your own stuff, and learning to self-care and honor your sacred space. I watch trash TV, then I get really zen afterwards.
Very good. Well, everyone, I thank you all so much. I can't tell you, these these times also lift me up. I myself battle with so much uncertainty of the future. As you can imagine, being a live events medical conferencing company, my world turned upside down in the beginning of March. And so I've just been kind of thinking about what's important to me and what are things I can do that have impact no matter what the outcome comes from this, because it is all uncertain. So I think, like all of you, the commitment really is to just do your best each and every day. You know, give it 150% of what you've got, because people are counting on you. And I think that's reflected in every single story and testimony that we've heard today, that, you know, every one of us are going in, starting our day thinking about, you know, how can I affect change on big scales, on smalls, and in our own homes. And I've loved being with all of you. I can't wait for the time that we can all be together again. And I look forward to seeing each and every one of you continuing to do wonderful things. I thank Pfizer so much for helping support this. I thank the patient advocacy organizations for everything you do every day to just try to reach people where they are. For you on the front line, doctors, you know, my heart is with you, my prayers are with you. I know you all personally. I have you can't see it with my background, but I've got a list behind me of all healthcare workers that I know, that I've come to call friends, and every one of your names is on it. So I just thank you for the things that you do. And I'm not alone in doing that. And Sherry, thank you for sharing your story, for being here, and for just adding to the conversation. Again, I thank everyone for watching. I hope you've taken something away from this,
Sarah?
and please share. Sure, oh, go ahead.
I think that one of the things that's been really fabulous for us during this incredibly difficult time is seeing the commitment of groups like yours, Total Health Conferencing. I mean, doing these programs is fabulous, and it was a great way to get around not being together. And we really appreciate your effort to support our patients and knowledge. Thank you.
Thank you. That means,
Thank you.
that means a great deal to me. Well, again, I thank you. I'm praying for all of us to get through this, and I can't wait for a time where we're all in a movie theater together, or at a Barnes and Noble, walking around looking for what to binge watch or read. So again, I thank you so much, and I look forward to when we're all together again.
Thank you.
Thank you.
Thank
Be
you.
well.
Thank you.
Thank you.
I know.
Thank